following webinar: RX for Coding, Coding for FQHCs, Coding Preventative Services. Now, before we begin, there are 3 housekeeping items to review. Number 1, this is a live presentation that we will be archiving on our website. Please do not put this call on hold, as this presentation might be interrupted by on-hold music. Number 2, please ask questions. Our presenter, Bonnie Hogue, encourages you to ask questions at any point before, during, or after the presentation. Number 3, this webinar is being recorded and will be posted on our website within the coming days. Thanks for your attention to these housekeeping items. I'm now going to go ahead and pass the presentation over to our presenter, Bonnie Hogue, who will be giving us an introduction on her organization, Brown Consulting, as well as a little bit of her background before we begin. So, Bonnie, it's all yours.
Thank you very much, Scott. And I am Bonnie Hogue, and I am speaking to you today from our office in lovely Twin Falls, Idaho. So it's nice to hear all of you, and I thank the Nevada Primary Care Association for working on coding topics that really matter to you. And certainly today's hour-and-a-half presentation on preventive services fills that need as these services are growing. Now, I want you to your printed material. I hope you've had an opportunity to get that printed. On the first page, you'll see bios. I'm Bonnie Hogue, and I actually have been doing coding and documentation training for the last 25 years. 20 of those 25 we have been working in federally qualified healthcare centers as well as rural health clinics. And today, 50% of our client base is actually FQHCs. We spend most of our time going to your clinics, reading records, looking at reports, training docs, training coders, and working with getting great documentation and great coding that then leads to great reimbursement and great compliance. So we always have those needs in mind. Today is not at all different. And what I want to go forward now with is on slide 3, you should be seeing my screen and today's agenda. I'm going to talk about diagnosis coding. As it relates to preventive services, I'll also talk about the actual preventive services, whether those are adults or well child checks. Maybe it's Medicare preventive services that you have a high degree of interest in. Then I know there are areas in coding that cause great grief, and they certainly fall into the categories we're discussing today. So we'll have some conversation about when it's appropriate to code 2 E&Ms during the same visit by the same doctor, or an E&M and a surgery. And I actually have extra slides on the minor surgical procedures based on errors we see in other clinics. So time permitting, I'll be visiting those slides with you as well. Now, if you'll look at page 30 in your training material, you'll see one of 3 additional handouts that we have included today. On page 30, and as you look at my screen, you see this miniature version of what we call BCA, or Brown Consulting Code Sheet. In the old days, this was an encounter form, and in even the older days, this was a, what do we call it, super bill. So it lists the services. It doesn't have the diagnoses, but it lists the services. Today's adventure in coding will deal primarily with the first column. And if you look at the top third, what you'll see are E&M codes, regular, problem-focused, visit codes. The bottom 2/3 is all prevention. So you're probably looking at the actual sheet. I realize and never intended for you to be able to read it off the slide, but know you have that resource. Then in my center resource is a single sheet. on E&M coding. And actually, we use this as part of a training project when we're teaching your clinicians how to choose their visit code. What's the difference between a 1.3 and a 1.4, and that sort of thing. But now, that's not the focus here today, but because we're talking about both problem-oriented visit codes and preventive visit codes, I thought it might be helpful, so I did include it. And the third additional handout actually is 3 pages, and actually it's right out of your ICD-9 diagnosis code book. And it lists the categories, about 13 categories in the V as in Victor code section that reference primarily prevention and screening and similar topics. So of course I want you to know that you do have all of those pieces. And on slide 5, what you're seeing is the value of coding. It cannot be understated. It's never been more valuable than it is today, especially as we're dealing with all third parties, whether you're dealing with a particular program, a federal program, whether you're dealing with Title X or other programs, or dealing with third-party payers. Coding is only in part about reimbursement. What coding really is creating an absolute mirror image match between the diagnoses that your patient is being evaluated and treated for today and the service that you're providing. So the better we are at all of this, the better chance we will actually present that mirror image match. These are my codes, and that means that is exactly what's documented in my medical record. ICD-9 will be with us, we believe, until October of 2015, when, in theory, we will go into ICD-10. So we'll review a few little tidbits on that today. Now, ICD-9 codes, just as a basis, just for clarity, have no dollar value. Pneumonia won't get you paid any more than bronchitis. However, they prove the necessity for doing the service. The dollar value codes are the CPT service codes and HCPCS codes. And the way their value is created is through a series that the feds put together in '92 of relative value units. Then payers use that, multiply by a conversion factor, and come up with allowables. You, clinics, use those same RVUs, multiply by a conversion factor, and come up with a charge. So the dollars are actually attached to these codes, but we go nowhere without the diagnosis codes. And since we're increasing our diagnosis inventory to many, many thousand codes, we have never more clearly understood this. And the sidebar of ICD-10 and ICD-9 is many payers today are working with old systems, and they can't even tell in some cases when we're not submitting correct diagnosis codes. It depends on the sophistication of the system they're actually running. When we actually do go into ICD-10, every payer system in the country will be updated. So therefore, they will then be able to recognize incorrect coding that in today's world they can't recognize. So it's a good thing to keep in mind. Now I'm going to speak to you about the 7 reasons you personally want to be the greatest diagnosis coder. First of all, diagnosis code identifies the reason for the service. It proves to a computer at number 2 the medical necessity for doing a service. Great diagnosis code also speaks to the acuity of the patient. Remember, when we're coding in physician services, whether it's in the ER, in the clinic, at a patient's home, on the bus, or wherever we're doing it, inpatient as well, the coding is all about today. It's not about the eventuality. It's not about the risk of disease. It's about what went on today. What's wrong today? What am I doing today? We also can address quality and meet many quality indicators by having the proper diagnosis coding. Now, the first thing that usually comes to clinics' minds are that diagnosis coding is important for payment, and I certainly do agree with that, but it is not the only thing. The thing that I enjoy the most thinking about is number 7. I want to be a great coder because in the future, there is every reason to believe that your actual diagnosis coding will affect your reimbursement. So just a great time. It's a good time to be a coder. We're moving from 9 to 10. A lot of that is a very lateral sweep. I know full well that 10 is much bigger, and there certainly are idiosyncrasies, but you will be delighted to learn that so much of it is so much the same. So the next thing I want to do is I want to talk about just 5 rules. When we code, we're obligated to follow ICD-9 official guidelines, which are nearly, not entirely, but nearly identical to ICD-10 guidelines. I've chosen my 5 favorites as they apply to what we're doing today. You, as a professional coder, you actually want to know from your ICD-10 book, ICD-9 and or 10 book, the Section 1 guidelines in your book, in the front of the book, which are disease-specific. They'll give me information on how to code AIDS. They'll give me information on how to code diabetes, pregnant ladies. That's Section 1, disease-specific. And the ones on my slide are actually from Section 4, which are physician service guidelines. Physicians, in this context, are what I call clinicians. For today's purposes, I speak of MDs, DOs, nurse practitioners, PAs, and possibly certified nurse midwives. So physician services, federally speaking, those are the people I'm talking about today. The 5 rules I'm interested in, and they're in shorthand. You review them in your own ICD-9 book by looking at Section 4. The first one I want to mention is that in the case where the patient has multiple diagnoses, the first listed or number 1 diagnosis is to be the main reason for the encounter as determined by the clinician. That's at the end of the encounter. In other words, it's not what the patient signed up for. It's not what the chief complaint says. It is in the physician or clinician's estimation, when there are multiple diagnoses, which was the one diagnosis that was the most energy intensive today. That's the number 1. And in the EMR, they have to be able to move them. Possibly it's the hypertensive heart disease that we haven't paid any attention to, and today that's critical. Or possibly it's a patient with multiple diagnoses, but today it is bronchitis. So it becomes the first diagnosis. So that has to be dynamic, and we have to make sure you as coders, I see you as educators. Your job is to train the docs, the nurses, the front desk, the billing staff, the management. We all work together to get this right. Rule number 2, code all conditions that either require the clinician's care today or affect the clinician's care today. So this is a guideline, and I neglected to mention the compliance with ICD-9 and 10 guidelines is required under HIPAA legislation, others as well. But HIPAA legislation is probably the legislation we best understand, where it's clear we have to follow these rules. There's no choice. Green Cross or Medi-Cal or Medicaid can't tell me to do it another way. I follow these guidelines, and so do they. Number 3, the highest level specificity we're going to code. For example, if it's an uncontrolled diabetic type 2 and they're on insulin, I'm going to code all that. That's very specific as opposed to just coding every diabetic 250.00. Rule number 4, and this actually goes back to Balanced Budget Act of 1997. The clinician is obligated in the medical record to identify the reasons for any studies, whether they're labs, imaging studies, or other, ordered. Sometimes that's very obvious. If I have a diabetic and I'm getting a hemoglobin A1C today, it's obvious why. But if I'm getting a chem panel, why? Is it for preventive reasons? Is it for problem-focused reasons? So my clinician has to identify that. That also is a requirement. And then the 5th one I'm including on my short list today is no rule-out diagnoses. If the diagnosis can't be confirmed, as you experts already know, we code instead the signs and symptoms. Now, I like lists, so I've used a few lists in this training. And on slide 8, what you see is common, very common every day, adult preventive diagnoses. You see ICD-10 on the left, and you see the ICD, I'm sorry, I said 10, but I meant 9, in black on the left, and the ICD-10 counterpart in blue on the right. So the very most common adult prevention diagnosis, V70.0. And then that's an examination. It says it's an examination. Then, for example, this one, V76.2, is screening of malignant neoplasm, cervix. So if I'm obtaining a pap smear for screening purposes, then in today's world, that's V76.2. Doesn't mean I'm reading the pap smear. I'm going to send it to the pathologist to do that. But I'm actually engaged in screening for cervical cancer. So these are common. And then I want to drill down on 3 of them, actually on 2 of them, and throw in a 3rd. First of all, we mentioned V70.0, the most common adult. And I love that it has not much of a description. Its description in ICD-9 is routine general medical exam. Then I also tried to look forward. I actually built this PowerPoint for this session. And I tried to look forward to the kind of things people struggle with and share those with you. First of all, I want you to know that with V70, it's perfectly okay to assign also the code for obtaining the cervical pap smear, because it's not inherent in this code. Remember, this code, V70.0, all it says is routine general medical exam. In fact, it could be a man or a woman. Okay, so it would be appropriate to code the V76.2 in addition to that if that's necessary. Now, if my patient's a 43-year-old woman, and she's also on birth control, then I could also assign a V25, which is contraceptive management, and its final digits have to do whether I'm initiating a method or following a method and what that method is. So that could certainly be an additional diagnosis if it was appropriate. Now, my 43-year-old, I might think it's time, as the doc, I get to be the doc in this one, to do cholesterol screening. She doesn't have disease. She doesn't have illness. It's not problem-focused. It's purely preventive. And then here's the part that people struggle with, or a part. I might also be coding any additional diagnoses that she has, that she owns, if they affect my decision-making today, or certainly, without saying, if it requires my decision-making today. So therefore, I might end up with diagnoses in my assessment and plan for which I did not actively engage today. Nonetheless, it's appropriate to have them there. What I really like docs to do, I'll tell you why they do it. They do it because they don't want to lose track of things. So they'll often include them, and it actually helps them to bring it all together. Maybe it's a preventive visit today, but they want to be crystal clear that they're remembering that this patient has osteogenesis imperfecta. So they might not be doing anything about it today, and what I tell them, what I like best, is I like them to say not addressed today. But at the end of the day, I can read that. I'm a coder. I read documentation. I can read that it wasn't. I'm not going to give them a bigger code, if you will, simply because it exists. It still is the truth. If it affects or requires my care. If it does not affect or require my care today, then I don't expect it to be there. So that's V70. It is the most popular adult preventive diagnosis. Okay. Now, we also mentioned V25. That is contraceptive management and family planning. Some of you may, or maybe all of you, are involved in a Title X federal waiver program, or you may not. It doesn't matter whether you are or not. This applies. But V25 is for contraceptive management, and in some cases, the patient might be getting a birth control pill, and the clinician believes that it is appropriate and, in fact, encouraged to do an annual exam. Don't code that here, because if you look at V25 and ICD-9, you'll see that that's included. So even if I'm doing an annual, maybe GYN exam, maybe less than a full exam, it's very possible that that my first listed diagnosis today, I dealt the most with contraception today, my note proves that today, then V25 is going to be my first code. And don't code a V25 in the first position with V70, which is just the opposite of what I said about V70. Then also, if there's a screening pap smear, use additional diagnosis codes. If I'm doing a screening pap smear, the pap smear itself is appropriate to code. Maybe I'm doing other screening. Then the most disturbing code on my slide is V7231. Very old school code. They all are, actually. V7231 is called a routine GYN exam with or without, key point, a cervical pap smear. Now, this is a very timely thing because the pap smear and breast exam and pelvic exam rules are changing as we speak. It depends whether your doctor follows guidelines of the American Academy of OBGYNs or the Federal Preventive Organization. They're slightly different over the next couple years. I'm sure they'll all settle down. But depending on what they're following, they might not be doing a pap smear on certain age groups, but every 3 years, or maybe stopping altogether. Or one of the current trends is not doing a breast exam, actually making sure the patients are doing their own breast exam. So, and there are reasons for all that. But nonetheless, this code was built in the days when a lot of women went just for a GYN exam, not to B70, which is a comprehensive exam. Certainly a GYN exam, if it's indicated, is included in a V70 because it's, as you recall from the CPT codes, it's a comprehensive service. So this is the one, unless I really needed to use this code, then I'd be much more inclined to be here unless it's focused on family planning. Okay, now the other thing that is historically why this code was popular is very short time ago, preventive medicine wasn't commonly paid by third-party payers, and certainly not through the Medicare program. However, this code often was. So in these days, prevention rules. So you will see with all payers, they're required to offer a certain level of preventive service. And the big push has come from Medicare with all its prevention. So actually, there's probably not so much use for this code. A couple of tips. If you are using this, then you don't, which is just the opposite of what I said in the previous two sections, use V76.2 with it. Why? Because the code says with or without cervical path. Okay, so that's interesting. I find it just annoying. Now, you might have done this and coded this with this forever, and you've never had a problem, and you think, what are you talking about? Well, when your payers update and they can pump in these rules because they'll be built into the the software they're buying, what a crummy reason to get a delay in your payment just because you didn't know not to do this with this. So what I'm saying to you is read Diagnosis Coding, pay attention to that soon-to-be antique ICD-9 Diagnosis Coding, and read it like you've never read it before. The more you know in ICD-9, the better you'll be in ICD-10. My next short list on slide 10 is, well, child check, by far, and they've been covered for years, not by all payers, but certainly by all state and federal Medicaid and related plans. And today's world, they're covered, period. I can't imagine you'd run into it not being covered. Whether it's covered or not, we're going to do it. And if we're going to do it, whether it's covered or not, we're going to code it right. So what I want you to notice is this is the most famous, V20.2, routine infant or child, any child greater than 28 days. Why? Because I also have these two codes that have only been around about 3 years, V20.31 and 32, health check for newborns less than 8 days or 8 to 28 days. And what were these developed for? Weight and color checks. Sometimes after the baby's discharged, or as a matter of routine, we're going to check that baby. And maybe we're not going to do a full-on well child check, but we're going to check the color, make sure we don't have jaundice that concerns us, make sure the weight is appropriate, but it might not be a full child check. If it was, then even if it was, I would use these. The thing that I like about V20.31 and 32 is, and I quote the American Academy of Pediatrics on this, it is appropriate to code these with small E&M visits, 99212, 99213, assuming the child's weight is fine and they do not have jaundice. I would obviously code a 99212 or 99213 if the child's weight was not fine, because I'd have a diagnosis code that said that, or if the child did have jaundice or a feeding problem or anything else. So we're constantly thinking about this relationship between the diagnosis code and the service code, and it starts with a good understanding of the codes that for some of you have probably been coding 15, 20 years. So it's always good to revisit the stuff you thought you knew. So my short list continues and actually just merges those two groups together. I want to show you just a couple of things. For example, remember these are ICD-10 codes on the right? And notice that when I get to the list, over here I have Z00.01 for ICD-10. I have no code that's the same in ICD-9. I love this. V70, we all know what that is. But if there are abnormal findings when ICD-10 starts, that'll be my code. I don't have such a thing now. Then whatever those abnormal findings are will additionally be coded. Now I want you to know that happens again with V7231, that annual GYN exam, and again with the well child exam. The other thing that's fun to notice down here, I have some other things like, for example, medical examination for sports physical. That's really common with kids, but not just kids. So I might be doing an exam specifically for that, or maybe for a driver's license. Now I want you to notice those two codes have, those two descriptions have exactly the same code. This is another one of those opportunities for you to go back and read what you already know. So if you go into the tabular list in your ICD-9 and you go to V70.3, it says its description is other medical exam for administrative purposes. Examples, and then here are the examples, including driver's license, could be DOT, immigration, marriage, school admission, sports competition. And what I need to tell you, if you're not an expert in ICD-9, when you see a list like this that's written as it is in your ICD-9 book, it's absolutely not all-inclusive. We can come up with other reasons that if a better code doesn't exist, that a code like V70.3 will be the code of choice. So I really want you to look at all codes and remember they're in those last 3 pages. At least the categories, I don't have every bit of detail, but your books do. And any software encoder that you might be fortunate enough to have. Or you can Google these codes and you will get full descriptions. So great time to update. Now this is sort of tied to prevention. The pregnancy test diagnosis codes are the reason, okay, for example, you do a pregnancy test to find out if it's negative or positive. That's the front line. The diagnosis code, this seems a little convoluted, is based on the outcome of that pregnancy test. So the diagnosis, the reason for having done the pregnancy test is based on whether it was negative or positive. Then we do have this category, not used very often, which says unconfirmed. Now, you wonder what that is. When might it be used? One example is maybe it's a patient on a diet and she's taking HCG drops or shots. Well, she may have a false positive pregnancy test. She may not be pregnant at all. So if she goes to the doctor and gets a pregnancy test, it may be positive, but she may not be pregnant. So a little bit of use for that. Now, the trick part is sometimes your patients are coming in and the nurse is following a protocol and getting some kind of a lab. That is a huge nightmare in diagnosis coding because nurses don't diagnose. Now, it's easy if my patient has diabetes and my doctor wants a fasting glucose. The reason is diabetes and it's documented. But in other cases, I'm doing a lab test or even an x-ray that's part of protocol, and we don't want the nurses giving diagnoses. Okay, think about that. Maybe if that seems problematic to you, that's something we'll be talking about a little later. Okay, so that's a little bit about the basic preventive, but let's talk about screening diagnosis versus what coding calls diagnostic problem-focused diagnoses. So screening just means, and you can refer to these lists. I hope you're taking a little bit of opportunity to do that in the back of your handout. Means it's just good health care. Patients of the proper age and may or may not have any risk factors, but I'm going to do screening cholesterol. My patients who need screening have absolutely no signs and symptoms and have no diagnosis for which I am doing a lipid panel. Now, if they have lipid disease, then they're down in this category where I'm actually continuing to evaluate and treat a problem. So that is a diagnostic exam. So I might actually draw the same 80,000 lab code, put it in the same colored tube, send it to the same laboratory, but the way it's coded and billed is different depending on whether it's screening or diagnostic. Okay, so here's another short list for you. These are just typical, average, run-of-the-mill family practice, used every day, screening diagnoses. And you can see them for ICD-10 on the left. And a 9, I've been thinking ICD-10 for months. ICD-9 on the left, and ICD-10 on the right. These are common, good reasons to screen patients. Okay, now when we talk about prevention, I also cannot avoid having some discussion about STIs, also known as STDs, sexually transmitted infections, sexually transmitted disease, same thing. And we do screening codes. So oftentimes it's good protocol if you're seeing a patient possibly for birth control, common reason, that we're going to do certain screening codes or an annual exam. Certainly, I do these in the absence of signs and symptoms. If they have signs and symptoms, I'm going to code those instead. So these are common screening. Nothing's wrong. Screening for HPV. Screening, actually the code says, screening for other specified viral disease. That's what I would use if I was screening for HIV. It could be screening for chlamydial disease. I don't have any reason to believe they have it, but I'm screening. So that's prevention. Problem focused is on slide 17. If I do know the diagnosis, then I'm no longer screening, and I don't code the screening, I code the diagnosis. So let's say I got it today, it was a quick HIV, I'm HIV positive, my doc confirms, this is a diagnosis of HIV positive. It's not screening, it's VO8. Okay, so, or if my patient has HIV, has AIDS, has HIV disease, okay, then it's O42. And once they have O42, they always have O42. It never goes away, not in these times. Okay, now I add HIV and AIDS, and I think of them differently. I add them to the slide, realizing that they're not always sexually transmitted, but they're often a consideration in sexually transmitted disease management. So these are not screening diagnoses at all, nor are these. So ultimately, and I can't decide this, if I'm the nurse, I'm getting a screening test or getting a lab, or I can't make these diagnoses. I have no business doing that. In fact, I am a nurse, and it's called practicing medicine without a license. So at the end of the visit, if I know what was abnormal, then I'm a doctor again, I just made myself a doctor, and one of these is the diagnosis, then it is the reason for my study or possibly my visit. So what I'm trying to do is build my story of preventive versus problem focused. So we'll carry through with that. Then there's contraceptive management, which is like a hybrid. It's easiest to think of contraceptive management, family planning, as prevention, but actually from a coding perspective, it's a problem. It's a problem to manage unintended pregnancy, which is what family planning, the way we use the term is, or contraceptive management, and very often involves hormones and treatments, so or insertion of devices. So in order for you to really think about contraceptive management and think about how we code those visits, sometimes it's a very short visit, follow up a patient on pills, and maybe she has questions, maybe everything is fine, but I have to see her to know. Then she's going to have a V25. She's going to have a V25 diagnosis. She's going to have a little code like 99212. She's not an annual exam. I'm not doing that. Remember, my codes have to match the content of my documentation. So sometimes we have to think a little differently. Anyway, this is the short list, but when you go to the slide and look at it, you can see these V25s are arranged based on whether I'm initiating a particular method, or down here surveillance, or following a particular method. And then there's this great code, V2509, and I could have republished it on the bottom of this list, which sometimes is family planning advice. You know, and patients often have lots of questions. So if I'm seeing the patient for this, one of these is my diagnosis, and there's a possibility, it depends on a bunch of circumstances, but I might also be getting a pregnancy test. So that would be an additional diagnosis. I just came 1 week ago, last week, I was working in a very large intercity health department with many locations, lots of family planning. And it had never occurred to them to code also the diagnosis for the negative pregnancy test. They say, well, that should be obvious. Well, nothing's obvious to a computer. And with one, they just signed up with a newish managed care, and they're not getting those pregnancy tests paid. And we thought maybe, I don't know if this is true, but it's very possible that there would be something built into the payer system. They're not recognizing a diagnosis. They're not automatically linking it to B25. That is clinical thinking, not computer thinking. So it's important for us to think differently as time moves on. So while we're talking about contraceptive management, this is funny. These codes here, V25, 11, 12, 13, they look like procedures. They read like procedures. Encounter for insertion of an IUD. Here's one, encounter for removal and reinsertion of an IUD. Sounds like a procedure. It's the diagnosis. It should say, diagnosis for a person who is coming in for insertion of an IUD. Then maybe that would make some more sense. So, and this is really important because another thing we see is we'll see a visit code. We'll see no insertion, very expensive, of the IUD, and we'll see a V25 code for diagnosis. Because in untrained hands, it feels as though we are coding the service. So, and that happens in a few areas in ICD-9. So be sure. And if you're monitoring your reports, then you're going to see these kinds of things if they don't make sense. There should be some kind of a relation. If I was a CFO, let's say, maybe I'm a CFO and don't know much coding. There should be some kind of relationship between the number of IUDs I bought in a 6-month period and the number that I inserted, according to the CPT code, in a 6-month period, and what's left on my shelf. And these can be expensive, so we want to be sure we're coding correctly. And of course, immunization's probably one of the fundamental preventive services. And the way to read the diagnosis, these V code diagnoses, is a need for immunizations. And they're specific for, and well, PPD is not really an immunization, but works in a similar way. Now here's a little bit of good news for you. In ICD-10, the immunization diagnosis code, there's one code, V23. And part of the reason this happened, I think, this is an editorial comment, is because there's other ways to know what immunizations we gave, like the CPT codes. And I think that from a data perspective, there wasn't good data out there proving how many immunizations and what we were really doing, because it was so labor-intensive just to find all the diagnoses and submit them, and often that's been a duty that's been delegated to clinicians who are not real detail-oriented when they have 4 patients waiting. And so as we move forward, at least we'll be able to easily pick up the clue that immunizations were given in terms of a diagnosis code. The last thing I want to mention about, as you think about prevention, is a group of codes for tuberculosis, for determining tuberculosis. Even though they're not fully screening codes, This one, V74-1, is completely a screening for pulmonary tuberculosis. This code, quite different, says that the patient has been exposed to tuberculosis. So they're coming in and getting an evaluation that's quite different from simple, everyday, run-of-the-mill screening because it's a good idea. Then sometimes there are some positives that then lead to us to do maybe x-rays or other tests, and maybe there's a reaction, but I, the doctor, am not yet willing to say this is tuberculosis because tuberculosis is a serious public health risk. The coding in ICD-9, which stays roughly the same in ICD-10, is fairly sophisticated. So be careful, and here I see this, we still see this today, where patients were doing rule-out TB and the patient ends up with a tuberculosis diagnosis. You don't want to do that. Okay, so that is the once-over on diagnosis codes as you think about them for prevention versus problem-focused services. Then the next code is, the next question in your mind is, how do you code the visit? What kind of visit is it? And the basic question is it a preventive service or is it a problem-focused service? Okay, so your question is, should today's visit be assigned a preventive E&M or a problem-focused E&M? Okay, well, your first clue comes out of the clinician-authored chief complaint and history of present illness. That at least tells me what information the clinician, not the nurse, not the MA, not the telephone, got from the patient about why they're here. Now, it's not the end of the story. It's my first clue. My final proof is in the clinician-authored assessment and plan. What does the clinician say this visit was really about? Patients might say, for example, I told you I was just working with a lot of family planning last week, and sometimes those patients are in a special program that only covers family planning. So they might call the family planning clinic where they love the nurse practitioner, and they might make an appointment. And the front desk will say, why? And the patient will say, because I'm having a lot of pain with my IUD. And so that sounds like a good thing to check out. So the patient comes in, chief complaint, pain with IUD. HPI, she's had pain with IUD since 1 month ago because the nurse gets this, and maybe she's had no bleeding. Then the clinician gets in the room, and the patient's real reason for being there is depression. And she says, oh, I needed to see you, but I knew I could only get in if it was about my contraceptive method. Well, guess what? At the end of that visit, the diagnosis is going to be depression, not a V25. Guess what else? That's going to be problematic for getting the service paid under her Title 10 program. But the clinician's coding will be a mirror image of what's documented in that record. And therefore, it will be compliant. Then we have to deal with the payment issue. Maybe the patient has to pay. Maybe it's sliding fee, a number of things. But at the end of the day, you coders are every bit as interested in the compliance of your documentation as you are interested in the payment. If we don't get the coding right, you'll never get the payment right. So just a reminder of what our life is about. Excuse me. Okay, read this slide. This is coming to you, this slide is coming to you, copied from information from CMS and from Noridian and Carrier and a variety of places. But it's coming to you from CMS. And it's not about preventive visits. Guess why? Because people that need preventive services, they don't have a chief complaint. Nothing's wrong. They don't have a history of present illness per se. People that have a sore elbow have an HPI. How long has it been sore? What have you been doing about it? What makes it better, worse? That sort of thing. So when I look at this slide about chief complaint and HPI, it can only be about problem-focused E&M services. And what it says is only the doctor, the nurse practitioner, or the PA may document the chief complaint and HPI. Now, I'm here to tell you that I know that in many clinics, if not most clinics, this has been delegated to the medical assistant or someone else. You need to know this is a problem and you need to deal with this problem, and it becomes a workflow problem. It is a problem that we can't deal with today, but I want you to know to worry about it and put it on your worry list and what are you going to do. And you might come up with an answer that if you're working in an EMR, you want a field that says nursing intake so that the nurse can put in all this information and the visit can start. But you don't want the nurse documenting the HPI, and there's lots of good reasons for that. Often they don't match what the clinician says later in the record. Often they're inadequate, inaccurate. The nurses, the MAs, were not trained to know what are the right questions to ask. So consequently, do know, with your take-home on that, is it's the federal government and CMS telling you that's got to be the work of the doc, nurse practitioner, or PA. Okay, so back to our visits and comparing. We're thinking about prevention using one side of our brain, and we're thinking about problem-focused issues on the other side of our brain. So these are prevention codes, 99381 through 87. Those are for established, these are actually for established patients. Then, of course, I have them for, these are for new patients, but I have them for both new and established patients. And over here are problem-focused. Okay, so these patients are coming in because they have a problem that needs to be solved, or they have a well-established or multiple well-established diagnoses that need to be followed. So these patients are coming in preventive on the left side. They're coming in just asking for your clinician's stamp of approval that they are healthy. They're coming in for preventive reasons. Okay, so now what I want you to do, and I don't want to change my slide, but what I want you to do is I want you to look at your additional handout material, and I want you to look specifically at page 30 and 31. So if you're looking at 30 and 31, on the top you see the problem-focused visits. And I want you to look under that first column that says MDM. That stands for medical decision-making. Okay, it's either low complexity, moderate complexity, high complexity, straightforward complexity. Now, if you look at the preventive services below that, there's no such column. Now, if you look back at my slide, what you see are the basic pieces of a preventive visit. Why are they here? For wellness. There's no history of present illness. That's for the sore elbow. That's for the back pain. That's for the, well, I'm here for my diabetes, hypertension, and heart disease. Okay, there's no HPI for true prevention. What is there? What do I have to do? You have to do an age and gender comprehensive history, an age and gender comprehensive examination. I need to do all the preventive counseling, and RF is risk factor reduction. that the patient needs. There's no time associated with these preventive codes. They could take 15 minutes or 2 hours, depending on the patient's needs. I'm going to end up with a preventive diagnosis code, and I'm going to have preventive follow-up instructions. And when you compare that to what is listed for problem focused, they all have a chief complaint or reason for visit. What is it? It's the problem. HPI. Let's go with the elbow pain. I'm looking for qualifiers. What's the location? Right elbow. How long has she had it? 3 weeks. How bad is it? She rates it at 7 on a scale of 1 to 10. What's the quality? What's the context? Has she done anything to make it better, worse, or the same? Oh, she's taken ibuprofen. Maybe that's it. Does she have any additional signs and symptoms? So these are 1 through 8. These are HPI qualifiers. This is all about problem-focused visits. Then what history is necessary for this problem? It's not a head to toe. It's not even, maybe not even the full extremity. What examination is necessary? What counseling is needed, if any? The codes that I use, which are problem-focused, do address time. And there will be a problem-related diagnosis. There will be some sort of treatment plan or follow-up. So I need to, as you're looking at page 30 in your handout, you're looking at some of those differences between problem-oriented services and preventive services. Now, according to CPT, according to the book where the service codes are written, there are definitions of who is a new patient and who is an established patient. So this comes right out of CPT. A new patient has not received any professional face-to-face services from the clinician or another clinician of the exact same specialty or subspecialty who belongs to the same group. One of you mentioned you have multiple clinics all over the place. That's one big group. It's not multiple small groups. But anyway, within the last 3 years, an established patient has. So that is the definition in CPT of what patient is new versus what patient is established. To continue with CPT, here are instructions given to the clinician when they might be covering, like, for example, Tracy's clinic, let's say Tracy and Nancy's group are in the same town and they cover for each other. Then you might be, Tracy's doctor may be covering for Nancy's doctor, therefore the patient is established because the patient is Tracy's patient. Odd, but true. And then this is just a little bit of an idea, some newish language in the last couple of years when you're dealing with NPs and PAs. And if they work for specialists, they're the same. So to review, going back to 29, new patient versus established patient. And the other thing I want you to know is the federal government and the FQHC program may not see that definition of new and established the same way. Yesterday, when I was on a CMS call about the prospective payment system for, actually I was listening to the recording yesterday, what the trainer said, who actually sounded incredibly competent, what she said was under the prospective payment system that the patient, if the patient was new in dental, the patient would not be new in medicine. Now don't take that to the bank. We're still getting more information. Some of you were on the follow-up call today, and there will be more information. But that will influence the code you choose, whether it's new or established. I want you to go with CPT code definition until further notice. I just wanted you to have a heads up. We'll see how that actually goes. So now read this slide. So this slide gives us great detail on what is really a new preventive visit. So it's new, the patient hasn't. Now if this is an infant, okay, this code right here, this is a new patient, and 8 is the indicator that it's new in this case. Infant. That baby is not new if my doctor saw the baby when they delivered in the hospital, just so you know. Okay, so this is the new description for a preventive service. And you notice it's everything we said on the slide, on the earlier slide. It is age and gender appropriate comprehensive history and exam, etc. Now my next slide is the same story, but an established patient. So these start with 9. And then the codes change depending on the age. All of which I realize you know, but it's always good to review it. So back here on slide 8, here are the pieces of what's included in a preventive service. Age and gender appropriate comprehensive history, exam, all the appropriate preventive counseling the patient could possibly need, any anticipatory guidance which is needed. Any addition, here's one that never gets done, never gets documented. I'm sure it gets done. Number 5, identification of the patient's risk factors. And then the clinician provides all the reduction of those risk factors that he or she could possibly think of. So these could be very long visits. Very healthy patients, well known to me, they could also be very quick visits. But they'll all have all these pieces. Or if it's not needed, my record will be clear that it is not needed. Then the ordering of any needed preventive laboratories or studies. Maybe I've got a child that I think is normal, but I'm worried about ADHD, and maybe I'm going to order some studies. Maybe I'm screening, or maybe there are behavior problems that should be identified, one way or the other. Excuse me. My record will tell the story. And then finally, any preventive or screening diagnoses will be assigned. So if these are the pieces, 1 through 8 on slide 33, these are the pieces. You could take a picture of this slide, make a photocopy of this slide. You could pull 3 preventive visits randomly. You could lay this paper next to it, and you could see if those pieces are in your records. That's your first step at auditing. Now, I don't expect you to know all the ins and outs, but you got to start somewhere. So you're looking at the diagnosis, you're looking at these pieces. Have I got these pieces in my record? That is the job of a professional coder. Learn auditing. All right. So if those are the pieces, then that's exactly what I'm going to do if I pull my record. I'm going to pull my preventive record. I'm going to look to see if this really makes sense. I'm going to look, and I know I'm going to be training about risk factor reduction because it's commonly missing. I'm going to look for those pieces. I'm going to look for the quality of the record. I actually want to see what it looks like. Not every preventive visit is the same. Now, I am going to show you very, very quickly 2 14-year-old preventive visits. Now, I type these, so I get to put things where I want them. And I happen to put this in reason for visit. But I could very well have this information show up in an assessment plan. Now, as I read this, 14-year-old female here, well known to me, prevents for a well child check. A review of her problem list and discussion with her reveals no chronic conditions, no particular acute concerns. She lives with her mother, father, 10-year-old brother. She's in the 9th grade at XYZ school. She likes math, science, literature. She's a B student. She's active in dance, and she has no interest or involvement in alcohol, drugs, or smoking. She's not dating. Perfect little girl. Okay. Then when you get, so you go through the pieces. I didn't bring all that forward. But at the end of the day, I have a diagnosis that says well child check, and I have a service code that says I did a well child check. Okay, now I want to show you another 14-year-old. 14-year-old female who's new to the clinic. She presented requesting a bag of Plan B for contraceptive management. After diligent encouraging by my nurse, she agreed to see me. She's been sexually active for the past 12 months with several partners. She is not interested in a birth control method per se. She just wants a bag of Plan B. Well, look what I learned if I've got a great coding doctor. He really did do a well child check. He also did contraceptive counseling. He did a pregnancy test, negative. She's a smoker. She has abnormal weight loss. He did screening for HPV, STD, HIV, chlamydia, and TB. Did he intervene? Yes, I called in the social worker to meet with her to discuss her issues and her solutions. I, the doctor, will see her back in a week. Now, this little 14-year-old up here is perfect. Quick visit. Everything's nice. This young lady was quite a different story. She didn't even want to be there. She wanted a bag of Plan B. She's 14. She's obviously needs help. Or I'm reading it that way. Oh, I didn't include my homeless diagnosis. I also have an additional information diagnosis that says a patient's homeless, because elsewhere I knew that she was. Okay, now the other thing is this is 10. Even if I had my homeless diagnosis in here, I can't remember the number, but it would be homeless. Oh, and I also have lack of material resources. Okay, so maybe I would have that as well. Lack of material resources. All right, that's 12 diagnoses. Can I submit all those on a claim in today's world in 2014? Yes. I can submit up to 12 diagnoses. So that's important to know. And you know what? There's reasons for that. Look at the story that this list of diagnoses told. Okay. All right. Okay, now I'm going to get this out of my way and get back to this PowerPoint. I think that was, I debated whether we'd take the time to do that, but I think that's worth it. Now here are the codes I think you need the least amount of lecturing on, and those are the problem-focused codes. So I take your attention back to page 31. I do want you to know I can pick these codes based on either counseling time or components, not the focus of today's training. That is the focus for clinicians who document. But I do go through it. I include the information. Maybe you'll be teaching your doctors. So it's medical decision-making, history, and exam. Then you have a picture of this tool. I like doctors to look first at their assessment and plan and focus on the medical decision-making, get all the diagnoses there, and then use the front of the tool or the top or bottom of the tool, depending on how you're looking at slide 31, to see if you have enough of the history. So you pick the MDM from the back and the history or exam if they're established, and exam if they're new from the front. So once again, these are also beginning auditing things for you. So here we are. We know something about preventive service codes. We know something about problem-oriented service codes. And the next question is, should today's visit be preventive, E&M, or both? Remember, or both. That's why this slide looks different than the last time you saw this. Now I want to talk about when you can code both. And what I want you to do when you're actually looking at your records is look at that assessment plan. Do they really have both? And it's not just the diagnosis. I need some extra history and exam if I'm coding a second visit. So, but the proof, the beginning proof is in the assessment plan. Now, I'm not going to read this to you, but this is quoted right out of your CPT book. And what it says is if during the course of a preventive service you are actually doing active words, you are actually evaluating and managing an important problem, you may code an additional code from the problem-focused codes. Then here's a reminder, coders. If so, if you do code both, you use modifier 25. Look it up in your Appendix A in your CPT book that says you did that additional work, that you have two E&Ms on the same day, and they're distinctly different. So what this says is from CPT, and this is true of CMS as well, it's appropriate to code two visits, a prevention and an illness, as long as you worked on that illness, not just that they had it. Remember an hour ago I was saying sometimes it's affecting the condition, but they're not really doing work. So I want the diagnosis, but it doesn't mean you get an extra visit. Now, to carry on, and I tell you right where to go read this in your book, if it's a tiny problem or you didn't do anything about it, don't even think about coding it. With that said, if you're going to code both a preventive visit and a problem focused on the same day, here's what I have to say to you. Okay, the problem focused will have some level of HPI and ROS. You already did in the wellness visit a comprehensive history and exam. So the problem focused visit will have to have a little bit extra. For example, here's the classic example. You've got a 2-year-old and they're here. Mom brings them in for a well child check. You're doing all the well child check stuff and everything's fine. Look in the ears, you see a bulging eardrum, indicator for otitis media. So the doctor stops dead in his tracks and he says to Mom, has this baby had a fever? Has this baby been pulling on their ears? That's called ROS. Has anyone else been sick? Does the baby have chronic ear infections? And does all that. There's no extra exam to do. There are a few little extra ROS pieces or HPI pieces. Then the doctor says, this baby has otitis media. This baby needs an antibiotic. Therefore, this doctor has action. Now, everybody in the world knows that if an established patient came in 2 years old with the story I just gave, Mom said, my baby's pulling at his ears, it would be a 99213 service. Here's what we say to you. If you're going to code a problem-focused visit with a preventive visit, keep the add-on E&M low. We say 99212, even though ordinarily all by itself it would have been a 3. Sometimes we here at Brown work for lawyers, and we have to defend this coding and documentation you do. That influences our way of advising you. So keep those add-on codes low. Then we say, if it's worth an extra code, it's worth an extra paragraph. I'm going to warn you, depending on payers, and you guys are going to have a whole bunch of payers in the next 2 years you never even heard of. All different kinds of plans. Depending on payers, the patient may be required to, if they have to pay copays, to pay 2 copays. You know, you take the good with the bad. We also have sliding fee scale. We have ways of adjusting things. We have the Primary Care Association, where maybe if it's a local Nevada payer, they can work with them on behalf. But first we have to code things right. I beg you, code right, even if you don't get paid. That's one way we study. And that's why I say to you, monitor the billing outcome. Monitor what happens, because you're going to have to appeal payment failures, and you're going to have to educate patients. The way your FQHCs look today could change dramatically over these several years, and I expect you to have more payers. Okay, so here is a classic example. Here's a well child check. It looks like established child, 4 years or under. I know that. I'm used to that code. And then I coded an extra 99212 with modifier 25 because I'm treating bronchitis. I'm going to say with antibiotics just to give it some beef. So I'm ordinarily, this bronchitis in this 4-year-old probably would have been a 99213 established patient. Today it's a 1-2. I used the modifier, and you know what modifier 25 said? I bet you already went and looked in your book. It says you did a significant separately identifiable evaluation and management service on the same day as another E&M as a procedure or service. So yes, this is okay. Yes, I know not everyone pays. If you do the work, code and document it. If you write it off, you write it off. But go on record for doing the work that is documented in your record. Okay. Now you guys, now it's your turn to do some work. What I want you to do is I want you to tell me, I want you to, and maybe Scott can help with this. Here are 6 questions. I want you to tell me, I don't want a code number, probably. I want you to tell me if I should code this as prevention or prevention and illness. So how can we do this? Nancy, can you guys give me an answer for number 1, your group? How do you want to do that? The rest of you look at these and start thinking, which way are you going to code it? Because we'll just run through these together. We'll count on each other. So number 1, you've got it in paper. You've got this in paper as well. So number 1, then number 2, the 8-year-old known to me, ADHD. Nancy, can you help?
Bonnie and Scott, she might be muted. Let's see maybe if Nevada Health Centers can chime in.
Okay. Okay. Can you guys help us? How do you want to code this? Be sure to unmute yourself.
Is this number 1 or number 2?
Go ahead with number 1.
Both. It's a preventative. It's both. It's both.
Both. Oh, yeah, I see Nancy's answer. Okay, I see your answer. You guys look at these. Look at these, and then we'll just take turns answering them. So here's the answers. Okay, let's see how we're going to do this. Let's see how this works. Number 1, I say I'm going to code prevention and a little tiny illness code. And it looks like Nancy agreed with me. Okay, Nevada Health Centers, what are you going to do with number 2?
Just the preventative.
How are you going to code it?
Preventative?
Okay. Me too, I agree. Preventative only. That's a well child check, and they have known ADHD. I said preventive only. You know what? You also have to be practical, and you have to teach your clinicians to be practical. Okay, number 3 and 4. Take those on. Whose turn is it? Tracy, can you help?
Sure.
Number 3, annual exam, elevated BP. What do you want to do there?
I'm going to say preventative and a small code.
I agree. I agree. Annual exam with elevated blood pressure, labs order, and yeah, I'd say there's action words here. We're doing something about it. Will you go ahead with number 4?
Sure. Can you put it back up? Sorry, I don't have the thing up, the code.
Yes, yes. Here you go.
Sorry
Okay.
about that.
Annual, and that's for blood pressure, liver disease. Oh, this is a good one. Okay. So it's annual exam, 48-year-old. I know her. She has stable blood pressure and lipid disease. I'm going to see her in 2 months for that. What do you want to do?
I'm going to say preventative. I'm going to say preventative.
You're awesome. You and I agree. So therefore, that is good. Okay, let's look at 5 and 6. We ought to get Scott in on this. Okay, Scott, it's your turn. Number 5, you're doing a driver's physical, and you discover cellulitis on this driver's forearm from a 10-day-old cat bite. And you're going to treat it with the antibiotics, and of course you're going to follow it up. This is a little scary. What do you want to do today?
I'm going to guess and say preventative and problem.
That is right. You're a coder now, Scott. Okay, then number 6.
Okay.
Now, this is an annual exam for a 30-year-old with refill of over-the-counter of birth control. Okay, prevention only. That's easy enough. Prevention only. Okay, good, good. Don't go away. We're going to do a few of these on Medicare in just a minute. Medicare, we do a whole 2-hour webinar on Medicare prevention. So, but I want to give you the highlights because there are changes coming under prospective payment and increases we're actually going to be using, and we'll be training on this in a couple of weeks. In fact, when we're in Carson City in a few weeks, we'll spend a lot of time on specific FQHC things, particularly some of these Medicare changes. Medicare prevention is not new. It's been a growing field. I need you on page 30 in your handout to look at that left column in the middle, C2. We call it Obamacare. So look at that. What I want you to know here, these are the websites. I actually want you to go to CMS and get these documents. Each one's 8 to 14 pages. They're well written. They're very helpful. And what am I talking about? Okay, so you are looking at Obamacare on here, and you're looking at the Welcome to Medicare visit, and you're looking at the annual exam, and you're looking at the subsequent exams. These will have values under prospective payment that will range from $154 to over $200 a visit. It has never been smarter for you to bring Medicare patients into your clinics. Okay, those will be the values. Now, I understand the single rate reimbursement. I get all that. But these are going to be enormously valuable, and they're, I like the way it's set up under prospective payment in terms of what the patient will have to pay. Again, I'm not here to talk about that today, but I'll tell you what I am here to do. I should tell you that I am a board member for on an FQHC here in my hometown, and we have about 25 providers, 20 to 25. And my own FQHC has been resistant to really doing outreach for Medicare patients. They are a great population to bring into the health center. They tend to want to be more compliant. They're probably not moving. And in the early days, they weren't popular in community health centers because sometimes we have very qualified physicians and clinicians in our health centers now, and we want to take care of these patients. So, without sounding like a salesman, these are the big pieces of what you need. You could print this slide. I didn't try this, but I could. I could print this slide, and I could go get a record that someone has coded to, what have I got going on here? IPPE, the initial Medicare visit, that someone has coded to a GO402, and I could do check marks and see if this service is documented. Start with a little bit of that. Then you actually learn more about the codes. So on slide 47, it's the IPPE, that initial Medicare. The annual Medicare is next. Many pieces. These services have felt very off-putting to clinicians, but actually it's not the clinician that does. The most of the work is done by a well-trained nurse or MA. We even have a couple clinics, I haven't looked at one of them, but I looked at the other, that have done YouTube videos on, they both are FQHCs, on doing these services. So that might be fun. Take a look at that. Anyway, here I have the first year that the patient's in the Medicare program, they get a welcome to Medicare visit. If they miss it, then they can always get an initial annual. You need to also be looking at page 30. You need to look at the numbers and the descriptions. So they can get an initial annual, and then every year thereafter they can get a follow-up annual. I want you to, if you're just getting into this for the first time, I want you to pay attention to this thing called HRA, Health Risk Assessment. And guess what? Someone already did the work for you. You go to the American Academy of Family Physicians. It's free. And here's the website. And there's a form. And as long as you're a clinic and a physician, like I can't give it to you. But if you're a clinic or physician, you can get it for free. And it can even be used online. You can actually put it into your EMR. But it says, do you live alone? How do you get food? You know, those kinds of risk assessment. So we're in a time when we're really doing a great job taking care of patients. Now, like I said, we do Medicare prevention in its own 2-hour webinar. So I knew good well that the best I was going to be able to do with you today is introduce the idea. We will spend some time on this in August when I'm in Carson City. So in the meantime, let me know what you want. Let me know what kind of things you want to look at, what works for you. Here's my short reminders. If you're going to do this, get them to sign a waiver. Patients sometimes don't even know that they have the service elsewhere. So if you don't, then it's a non-covered service. Most services are provided without, most Medicare preventive, there's 0 patient copay. Very popular. Okay, number 3, you may code Medicare prevention and an E&M, except what I do need you to know is after physician payment, after PPS kicks in, you won't get 2 encounter rates. So, okay, that's all right. We'll get through that. And then I do not want you to use these codes. And I've got FQHCs that are using these. Now look at these. You recognize these codes. They're preventive CPT codes. Don't use them. We have codes for Medicare. They work. They're reimbursable. They're no out-of-pocket to the patient. If you use these codes, then you need to know they are not covered by the Medicare program. Now, I'm here to tell you that I know that some clinics have gotten paid using these codes. They bill on the UB. They say it's a 520 revenue code. Anyway, they get paid. I'm aware of one clinic that then was audited and paid all that money back. So I don't want you to be paid incorrectly. So avoid all that. We'll have another talk. If you want to talk about this, you call me. But don't use these codes. Okay, here's your quiz. Here are the quiz questions. I made this slide a little smarter. So number 1, you guys start, and let's start with Nevada. Ms. Santos.
Nevada Health Center.
How are you? Okay, number 1, how should I code that? 65-year-old IPPE and and an initial evaluation and treatment for hypertension. How do you want me to code that?
I have a question first. Is the hypertension a new diagnosis?
Is the hypertension what?
A new diagnosis?
It is a new diagnosis. It says initial evaluation, and I'm treating them. So that was a fair question, though. In other words, it's not just that he has hypertension. I've actually got action words going on.
Okay, so then it would be both for the IPPE and the E&M.
That's right. I agree with you. I agree. You're on a roll. Do number 2 also.
Just the G code.
Let's see. 70-year-old initial annual follow-up evaluation. A follow-up evaluation of memory loss worsening and referred to a neurologist. Okay. Now, you don't have the advantage I have. I made these patients up, so I knew what I was thinking. But there you go. There's what I want you to know is he really evaluated. He's following up this memory loss. He's evaluating it. It's worse. Okay, I have one problem worsening today. Today his take action is he says, ooh, I'm not so sure about this. I better send him to a neurologist. At least that's the story in my head. Your key points are that we really truly evaluated him to the point that I can tell he's worse. It's not just that he still has memory loss, and I don't know what to do about it, and he's sending him to a neurologist. Now, let me tell you something. I've had to defend records where third parties say, well, he didn't do anything. Yes, he did. That's what medical decision-making is. What my doctor didn't do was document well. Good job. Very good job. Okay, Nancy, will you take on a couple of these? Can you do number 3?
I'm sorry, who did you say?
Nancy and company. I think you have a few people with you. How would you code number 3? And you're probably looking at page 30. And then I'm not asking for a particular E&M code if one exists. Do you have any? This is a little bit of a trick question. Let me show you how I would do it. This is a trick question. Take you 5 minutes to find these codes. Okay, number 3, I would code the subsequent annual visit. Okay, and you're looking at Obamacare. And I would also code something no one thinks about, and that is my doc spent 5 minutes talking about tobacco cessation. For the Medicare patient, that is this code. I have to document it and document the time. And my doc says, you know, this is where you have COPD, you have this, you have that. I don't want you to smoke. Here's some choices. You can call the Nevada Quit line, a variety of things. And, of course, I would have the diagnosis that says my patient's a smoker. I want you to code what you do. I want you to code what you do. The 70-year-old subsequent annual evaluation and med changes, okay? So here you have the subsequent evaluation and the E&M code. Okay, Tracy, can you help with the last 2?
Okay, for number 5, I'd say you're going to code for the preventative, but also the alcohol screening. There's a code for that. It's a G code, I think. Is that right?
I think you're right, and I see it on page 30. I see those alcohol and substance assessments.
Yeah.
I see those in section E, so I think you're right. I'm going to code the E&M because he's here for heart disease, and I don't try to say what level. And then I did the assessment. Oh, and a separate, these are both time codes, you guys. These 2 are timed codes for Medicare. There's almost nothing here I don't also have some kind of CPT code for. So my doctor documented just enough detail that I'm going to code these services.
For the screening, right?
You know,
Okay.
that's right. That's right. You're right. Okay, and what do you think of, are you answering
Number 6?
7?
I'm
Six. You're right. There
I
you
was
go.
just going to say regular visit. Regular preventative?
Well, it's without any known problems, and they're here for an annual exam.
Right.
So they're 67. So you're right on. Okay, it's 08. 08. Let's see. 08. GO4. 38. It should say. Oh, it does say 38. But what do I want to make a big deal about? Don't use this. You know why? Because he's 67. Okay. All right. And our time is up. But you have these slides. And sometimes you can code an E&M when you really did the work and the procedure. And now you'll follow my logic. So you'll see you use on the E&M modifier 25. And sometimes you don't. So if you saw a patient, okay, because it's fresh on my mind from last week. Nurse practitioner sees a patient, and the patient can't make up their mind what kind of birth control they want. So they finally say, I'm going to talk to my husband, and I'll let you know. So she goes home after the lengthy visit. There was a lot of counseling, and then she calls up and schedules an appointment to come back and have an IUD put in. Okay, when that patient comes back for that IUD, do not code a visit. I know you're an FQHC. No, it's not necessary you code a visit. An FQHC encounter is a medically necessary face-to-face visit. Okay, now I will stop. These are the ones I want to show you up here. I thought maybe I wouldn't get time, and lo and behold. But do look at them. And again, this is more stuff that we'll be doing in Carson City. We'll be doing exercises. So I want to thank you all for coming. Notice there's a way for you to send us coding questions. It's on the last page. Feel free to do that. Always tell us that you're an FQHC, because we know that's what that means. And I think I've got these dates on here right, Scott, and you'll probably be sending out information.
Yeah, so like Bonnie's slide says, stay tuned. We're going to be doing 2 ground-based coding sessions, Tuesday, August 19th, Wednesday, August 20th. The sessions repeat, so there's not new content one day versus the other. Whatever material is received on the 19th will be the same material that is received on the 20th. So I will plan on sending that info out to folks soon, and please look for that announcement. Then the other thing I was going to wrap up on is if you check your email, I sent out a survey. We're most interested to know what you thought of today's webinar. And aside from that, Bonnie, unless you have any other comments, I think that we're going to go ahead and wrap up.
Okay, I just added one comment. In Carson City, if at all possible, bring your CPT and your ICD-9 book, because we're going to try to do a lot of workshop stuff and actually solve problems. And with that said, I am done, and I thank you all for your attention today. I've enjoyed you.
Thank you.
You're welcome.
Bye-bye.
Okay, thanks.
Bye.